Hi everyone, my name is Eric Lineburger, anesthesiologist from Brazil, from the cardiovascular committee of the Brazilian Society of Anesthesiology, and we are going to talk about hemodynamic and other monitoring during weaning off CPB. I have no conflict of interest unless for involves monitoring that I'm going to talk in the end of the lecture. It's assigned in our department for research purposes. And in the next few minutes, I'm going to talk with you about arterial and venous pressure waves, cardiac output monitoring, starting from macro circulation, and pointing some monitors like invasive, minimally invasive, and non-invasive monitors of cardiac output. Then talking about microcirculation monitoring, which is a promising tool, and other monitoring that we can use for help us to weaning off CPB, like near infrared spectroscopy and processed EEG, and finishing with some conclusions and perspectives on the subject. Invasive arterial pressure waves are common and the most frequent monitoring. The objective is to measure the absolute values, analyze arterial waveforms, which is very important in the weaning off. It's almost what our surgeons in the other side look when we are weaning off CPB. So we have to understand the physiological determinants like the ventricular vascular coupling to form the pressure wave. And it serves for us to evaluate global hemodynamic status when weaning off CPB. We have to realize, as I think most of the audience know, that we have different waves along the path to the central pressure to the periphery. And here is a quite normal wave, which is showing the upstroke systolic curve that we can use as a surrogate measurement of efficiency on systolic ejection. Here is the dicrotic notch, which is very useful for starting to look for vasodilation and so on. Here's it's a curve that we can see that's quite bifid here, and sometimes a patient with obstruction of the left ventricular outflow tract can exhibit this kind of wave. A vasodilated patient with the dicrotic notch away from the 2/3 of the systolic collapse that we can use to guide the response of the vasoconstrictors, augmenting and showing this normal pattern here, return to the normal position of the dicrotic notch, then fading away to vasodilation again, just looking at the arterial pressure wave. Some patients exhibit these several reflections during the systolic phase and the diastolic also, showing a patient with microcirculation damage from atherosclerotic plaques and so on. And we can use as a surrogate measure for normal cardiac output in the weaning off CPB, or low cardiac output, just looking for the area under the curve and a slurred upstroke systolic, and we promptly have this situation to ensure that if it's okay or not the weaning off. So talking about central venous pressure waves now, we have the CVP, the central venous pressure with our components of the systolic kick, the contraction of the ventricle and the C wave, and the negative waves X and I, and this could lead us to some diagnosis too. Okay, we have here a Canon A wave with AV block, and we can diagnose. We have an example of pericardial constrictive disease, weaning off CPB, with large X descendant waves. It's a helpful diagnosis just looking at the CVP wave here. It's another case of a patient before CPB with normal A, C, and V waves here in the top. And in the bottom, we can see these curves with a CV wave together, showing that the patient is with right ventricular failure and overload of the atria. Pulmonary artery catheter was introduced in the 70s. It had a great popularity in the 90s, and was gradually decreased over time because large randomized controlled trials failed to show a benefit in outcomes. So as it's invasive monitor, it's time consuming because in experienced hands we have like 20 minutes to ensure a good position in experienced hands, and it's subjected to complications. Less invasive monitors emerged, and it was somehow discontinued after the 90s. So we have to ask ourselves, it's still place for pulmonary artery catheter? And I say yes. We have some data showing that in the last few years we have an increase here in the use of the pulmonary artery catheter, especially for heart failure. And it's excellent in reliability of measurements. It's excellent, and we can show a lot of data here, a lot of measurements that help us to weaning off CPB that other monitors lack for us in terms of information. It's subjected to complications. The majority part is from dysrhythmias, and we have the indication nowadays to use the pulmonary artery catheter in severely committed patients with low ejection fraction or restrictive diastolic dysfunction. And when Jeremy Swan was looking at regatta here in Santa Monica Bay, he realized that some boats use this sail that is called the spinnaker. When they put the spinnaker, the boat was running very fast. So he had the idea to put this balloon into the tip of the catheter. Okay, and what do I mean with that? It's the same as wind. You have to have a good wind to move the boat. So you have to have a good flow of blood to move the tip of the catheter. And I think when we submit this patient to anesthesia induction, like 22% of ejection fraction of the left ventricle with a restrictive pattern of diastolic disease, we can make difficult after induction with hemodynamic instability to put the catheter with the corrected flow. So what I do for the last years is use anesthesia induction with already in place the catheter. What I mean is that I put the catheter with a awake or minimally sedated patient with preserved flow, because when we are using this catheter just after induction, we can be using this while the patient it's in hemodynamic instability. So I think it's easier to pass with the awake patient. You see here it's a 86 BIS value, showing that the patient is minimally sedated, and I have decreased my rate of complications. So it's a reliable and operator-independent monitor for cardiac output and pulmonary capillary wedge pressure. For right ventricular failure, you have more information than just visual, because you add pressure flow-based information in congenital disease, right ventricular failure, pulmonary hypertension, in LVAD implantation, and in patients with contraindications to TE2. There are several papers now showing the benefits of analyzing together the pulmonary artery pressure along with right ventricular pressure, analyzing these waves, these curves with special catheters. There's nice papers from André from Montreal in this subject. So we have a place for pulmonary artery catheter for sure. What kind of monitor can I use nowadays? We have to choose between invasive, minimally invasive, and non-invasive, and I think it's well described in the literature that under general anesthesia, with a patient that the type of patient that we anesthetize for cardiac complex surgeries with comorbidities and low ejection fraction, with pulmonary hypertension and high degrees of diastolic dysfunction, we choose the thermodilution by Swan-Gus catheter, and revising some of minimally invasive and other catheters like the thermodilution transpulmonary or lithium dilution like PICO and LIDICO. We have a place for these catheters too, but I think in less complex cases, I have used this catheter in the last years, like mostly the Vigileo by arterial wave analysis and the PICO, and they have some limitations I'm going to stress now. The minimally invasive catheters, they have the problem that even when they were first described in terms of demographic analysis of the arterial wave to obtain the cardiac output value, it's limited by the presence of atherosclerotic lesions and irregularities, and we have some limitations because of the cannulations. So it's the kind of patient that we have in cardiac surgery with plaques, with limited area or diameter of the arteries, and tortuosities that impede the correct measurements sometimes. And for thermodilution, transpulmonary thermodilution or lithium dilution, I'm going to explain here a little of the PICO catheter. It has a good correlation before cardiopulmonary bypass, but like we see here, and when we compare here using epicardial echocardiography, but the problem is when you are off during weaning off CPB, you have some disagreements with the measurement of the central pressure and the measurement of the peripheral pressure. So it's reaching their maximum values at the end of CPB, and it's subjected to some some wrong measurements. So it's indicated in less complex patients, but minimally invasive, like pulse wave analysis, are a good indication for volume reposition and analysis of the variation of the systolic volume. But we have to be careful in patients with restrictive diastolic dysfunction because subject to wrong measurements. So it is a 2B class of recommendation by the guidelines of cardiopulmonary bypass, recent released, and it takes the same indication and same level of evidence of indication as the Swangus catheter. So they are more modern monitors, but didn't seem to agree very well with pulmonary catheter. Like the agreement, it's, if I'm not mistaken, like 40%, which is not a true indication for monitoring after CPB. Microcirculation, it's very important. It's a complex network of arterioles, capillaries, and venous. In CPB, we have non-pulsatile flow, inflammation, hypothermia, hemodilution, and even in preserved cardiac output, we have the coupling of macro and microcirculation, and this can occur and leads to tissue hypoxia. And we can have a normal cardiac output, normal cardiac index, and the patient is with low perfusion. It's a network of vases, of capillaries, of venous, and we have lesion of the glycocalyx and leads to hypoxia after weaning CPB. It's more important after CPB, these alterations. We have NIRS monitoring as a monitoring that we can use as a surrogate measure for this microcirculation. And we see here in the preoperative period, like the pre-CPB, talking better, the pre-CPB period, we have these great variations in the flow using NIRS as a monitor of tendency, okay? And we have after the CPB a more flattened pattern showing that the patient is exhibiting some microcirculation disarrangements in the clop and with macro and microcirculation. It's a very time fashion monitor. This is a mean arterial pressure showing this tendency, and it's quite similar of the tendency of the NIRS monitoring. We can use for diagnose rapidly changing hemodynamics. In this example, we have a patient with right ventricular failure and showing a very rapid and time fashion decrease in perfusion, like you see here. We can use for driving some decisions in ventricular systems or ECMO. In this example, we have an instability in the postoperative period. The patient needs intraballoon pump counterpulsation. We talk of the intraballoon pump counterpulsation to put the ECMO, and you see here the level of the perfusion is low, and we took the balloon off. The patient has instability, and then he recovers after ECMO to a higher level of perfusion. We can use NIRS plus bilateral BIS. We can use these monitors of cerebral electroencephalographic patterns. Okay, and together with NIRS, we have great information for weaning CPB. This I show the BIS asymmetry. It's a difference in potency between hemispheres. It's showing that the left hemisphere is with different in potency compared to the right hemisphere. it's always pointing to the hemisphere that is with low perfusion. You see here that's low perfusion in the left, and the asymmetry here is pointing to the left too. In this case, we have a patient that has this low perfusion in the left, in the right hemisphere, and we correct this to ensure that the patient is returning to the normal perfusion. And as this example, we can in the weaning of CPB, realize that the patient is with low cardiac output, and we correct the cardiac output based in the cerebral monitoring. As well, with right-sided pressure overload, and as I can see it as an example, right ventricular insufficiency after weaning of CPB, we have this big CVP showing insufficiency and right atrium with overload, and we can see that it's very near the correlation of the suppression of the EEG when compared with CVP. So we can use optical nerve shift diameter to see the adequacy of the relief in the pressure of the right side of the heart. And when we correct the stasis of the cerebral venous system, we can realize by this diminished optical nerve shift diameter, along with a amelioration of the tendance curve of the NIRS. And that's well described in a paper here by these authors, showing the close relation of suppression ratio and the CVP in real time. So we revised some arterial and venous pressure waves, cardiac output monitoring, talking about microcirculation monitoring in this several type of monitoring, showing some promised tools for monitoring microcirculation during weaning off, and how we can use cerebral monitoring to ensure a good hemodynamics for weaning off CPB. I think we're gonna, in the next years, see more papers about microcirculation and its role in the prognosis of the patients in cardiac anesthesia. I thank you for the audience and the time.